And now to add a touch of engagement and to test our clinical instincts, we have the young dynamic intensivist from Australia. And it's my pleasure to invite Dr. Swapna Chitra Vijayakumaran. She is the fellow intensivist and I would say fellow of like intensive care at Canberra Hospital after doing all her like in the degrees from India, MD and DM critical care from Tata Memorial Hospital, Mumbai. So she will be leading us through an exciting and interactive segment that is tumor versus trivia. Tumor versus tubules, a trivia. And so I would encourage all the young trainees to get ready to think fast and participate in this learning, which is fun and also informative. Over to you, Dr. Swapna.
Thank you, sir. Thank you for that lovely introduction. And I also would like to thank you for this very privileged opportunity of sharing space with such eminent senior nephrologists and critical care people here. So I was trying to share my slide. Is it visible?
Yes, yes, perfect. Please. Yeah.
Yeah. So before diving into the session, so I'd like to highlight a few things. We have some 8 to 9 questions, and it includes both common scenarios and some very rare scenarios as well, because this being a quiz session. But I cannot insist more on the basics that the seniors just taught us. So while encountering every patient, I'd like all the attendees to keep in mind that addressing the basics like the hydration status, ruling out an obstruction, and treating an underlying infection. These are much more important, and then we can, broaden our horizon into thinking about the other syndromes and other, situation-specific conditions in nephrocritical care. So let's start. So we have the first question. This is a 42-year-old woman with a new diagnosis of endometrial stage 3. She is admitted electively in the ICU for chemotherapy. She has a 17 cross 11 cross 8 centimeter mass and a very high, very high tumor burden. Her baseline creatinine is 85. She receives the first cycle chemotherapy. On day 3, she becomes nauseous and develops reduced urine output and is transferred to the ICU for worsening oliguria and tachycardia. Heart rate is around 180. She is a bit hypotensive with a blood pressure of 92/58. She started on low dose noradrenaline and resuscitated with 2 liters of crystalloid. And promptly for the hyperkalemia, she's also started on insulin dextrose and calcium gluconate. So her investigations are as follows. Potassium is 6 point. Just a second. Yeah. So the potassium is 6.9, uric acid is 1000 micromoles per liter, and phosphate is 2.8, calcium around 1.5, creatinine is 310. The ECG shows a persistent peak T wave.
Sorry, I can't help with that.
So the question is, what is the most appropriate next step? So do we continue aggressive fluids and give the patient transuricase? Or do we repeat the insulin dextrose? Do we start bicarbonate infusion? Or should we initiate an urgent renal replacement therapy? Any takers? This is a simple question I'm starting with. Anybody from the attendees? So the answer is B. The appropriate step would be to initiate an urgent renal replacement therapy. So if we go back to the VNet, why this becomes important is that now this is not a routine case of a TLS. Here we are having a female who's diagnosed with an endometrial CA. First of all, it's not a hematological malignancy, and it's very, very rare for a solid tumor to actually present with TLS. But we should always have it in the mind, in the back of our minds, when we are dealing with a large tumor, which is aggressively proliferating, and especially when the patient is in the early phase of chemotherapy. So, how do we not miss those solid tumor patients who present with these classical symptoms of TLS? That's where the role of the Cairo Bishop's criteria comes. So, it includes clinical criteria, laboratory criteria for TLS. So, the tumors which are with a high proliferation state, large tumor masses, patients who already have a pre-existing renal insufficiency or an obstructive uropathy, elevated LDH, uric acid, and associated dehydration. These are all risk factors for TLS, irrespective of whether there is a solid tumor or a hematological malignancy. Again, the lab criteria, we're all very familiar with the classical TLS criteria: elevated uric acid, elevated potassium, elevated phosphorus, low calcium, and the clinical criteria includes creatinine greater than 1.5 times the upper limit of normal, the presence of a cardiac arrhythmia or the incidence of sudden death, or the incidence of seizure. Moving on to the next question. So we have a 70 kg, 56-year-old female with AML on induction therapy with a VCR daunorubicin-based regimen. The patient's neutropenic on day 11. She's admitted to the ICU with confusion, facial swelling, and diplopia. CCT is done promptly, and it reveals a rhinocerebral mucormycosis. The patient is initiated on liposomal amphotericin B at 5 milligrams per kg IV. So, going on further, she develops an ST segment depression and a T wave inversion. Her laboratory parameters are as follows. Urine output is around 7.5 liters per day. Creatinine is around 242. Initially started from 88 and gradually progressed to 242. Potassium at presentation was 4.3, which had gradually fallen to 2.8. Magnesium is 0.45. Bicarb 18. Chloride 111. Urine analysis is bland with nil cast. Renal ultrasound is normal. So the question is, which of the following statements are false regarding the mechanism of nephrotoxicity of LAMP? So I'm actually bringing up LAMP in an Onco nephro critical care situation because it's one of the very common drugs we use in oncological patients for obvious invasive fungal infections. So we do encounter this scenario very often in our ICU. So the options are, so actually the question is about which of the following statements are false, which means only one of them is false and the rest of all of the mechanisms are actually right. So the first option is hydrophobic part of LAM binds with sterol and induces pore formation. LAM causes resistance to arginine vasopressin causing nephrogenic DI. LAM-related hypokalemia due to aldosterone receptor upregulation. LAM AKI due to reduced GFR from renal vasoconstriction. So which of the mechanisms among these four options is wrong while we try and explain a liposomal amphotericin B related nephrotoxicity? Any takers? Anybody? So I'd just like the attendees to raise their hands if I'm missing somebody or Just unmute and talk. Otherwise, I'll proceed on to explain the answer. So the correct answer is C. Lamb
Somebody answered
hypokalemia
D.
due to aldosterone receptor upregulation is the wrong option. So, how did we arrive at that option? So, what does lamb do? Lamb basically, it's a pore-forming antibiotic which actually inserts pores in the luminal surface of the tubular membranes. And what happens is that it makes this membrane leaky to H plus ions, and the H plus ions are taken back into the serum. In turn, there is loss of other electrolytes like potassium, magnesium, and calcium. So that is how the patients end up with hypokalemia. And because the H plus has already leaked back into the serum, there is decreased tubular secretion of H plus ions. And now there is more retention of H plus ions in the body while the urinary pH is alkaline. So there is inability to acidify the urine pH. That's how the distal renal tubular acidosis occurs. So now this pore formation is not restricted only to the tubules, it is also extending into the collecting duct, and it makes it resistant to the action of intrinsic arginine and vasopressin. That is how LAM patients have this huge urine output, which in our case was around 7.5 liters, signaling a nephrogenic DI, which is ongoing. And then coming to the reduced GFR, similar to other positively charged ions, the mesangial cells become leaky to the chloride ions, and in turn, the tubulo-glomerular feedback is affected, and that is how the GFR decreases. So this slide summarizes the mechanism of nephrotoxicity of LAM. Going back to the options, so all A, B, and C are right options, but we can, even without knowing all this, we can still rule out C, because if we look closely, the option C says it's LAM hypokalemia due to aldosterone receptor upregulation. But if we go back to our VNet, this patient, what's so different that cannot correspond with aldosterone upregulation? So in any hyperaldosteronism, along with the hypokalemia, what we observe is a hypochloremic metabolic alkalosis. Whereas in this patient, the bicarb is already slightly on the lower side, and the chloride is actually slightly on the higher side, but let's say it's normal. So that there itself, it precludes that it cannot be an aldosterone related mechanism. So whether we know all these detailed mechanism or not, still it cannot be anything related to aldosterone. Moving on to the next question. So then we have a 68-year-old man with no known hematological diagnosis. The patient is presenting up front. No malignancy diagnosis is made yet. He presents with 2 weeks of fatigue, unreduced oral intake, and progressive oliguria. He has a background of hypertension, and he took recently NSAIDs for the back pain. He's drowsy, mildly volume depleted, and is admitted to the ICU for worsening renal failure. Blood pressure is around 95 by 60. Urine output is 0.3 mils per kg per hour. Creatinine is elevated, around 5.8. Urea is around 32. Calcium is around 11.6 milligrams per deciliter, and hemoglobin is 92 grams per liter. So serum albumin is 3.4 grams per deciliter. Urine analysis reveals a 3 plus proteinuria. Urine albumin creatinine ratio is around, it's normal basically. And the urine protein creatinine ratio, on the other hand, is elevated, and it's around 3250 milligrams per gram. So now we know that we are dealing with some sort of a proteinuria, and with the background of the back pain and other things, we suspect some sort of a plasma cell dysplasia. So serum 3 light chain levels are made, and it reveals a markedly elevated lambda chain levels around 1800 milligrams per liter. We have, like normally in all ICUs, we do send the protein electrophoresis, but it takes its own time to come back. Similarly, the results are pending in this case also. The renal ultrasound shows absolutely normal sized kidneys. So, what is the most appropriate next step in the management? A, do we initiate steroids, considering it's a hypercalcemia of malignancy untreated? Should we arrange for the renal biopsy because we don't know what the diagnosis? Or sorry, let me just display that again. Yeah, I think I displayed the answer by mistake. Anyway, so let's go on. So initiate aggressive IV fluids and an urgent bortezomib-based chemotherapy, or should we opt for a high flux hemodialysis? It's a bit of a complicated question. Just summarizing, this patient presents with back pain, some hypercalcemia, proteinuria, no albuminuria, elevated lambda chains in the serum, and absolutely normal sized kidneys. Any takers on what we are dealing with and what should be the appropriate next step? Anybody? We have a very quiet audience. It's okay, make an attempt. It's okay to be wrong.
Somebody has answered C. Just now someone answered C.
I actually already displayed the answer if they saw that somebody could have.
Yeah.
Yeah, that's right. I give it to the attendee. Let's act like they did not see the answer. So would you like to explain your answer? Why do you think C is the answer? Now they'll be like, you're asking for too much.
Oh no, somebody's writing. He's
Please
written MM.
unmute and talk. That will save time for all of us and it'll be more fun.
No, I don't think so. Doing just
Okay.
answered MM.
Yeah. So, I mean, the answer is right, of course. So let's dig into why it is C. First, I'll tell you why it cannot be the other options. First, we are not just dealing with hypercalcemia. We are also dealing with some sort of a proteinuria. And there are signals, quite a few points in this history, in the VNet, to suggest that there is some sort of a plasma cell dyscrasia going on. So it cannot be just initiation of steroids for hypercalcemia. Next is arranging for renal biopsy. The question is about the most appropriate next step. So renal biopsy will definitely help at some point. But if you ask me, is it the next most appropriate step that I'd be doing? No, probably we have to address some other main issues before actually digging into the evaluation aspect of it. Now, coming to the hemodialysis is a good option. But in this case, specifically, if you observe, what is elevated is the free light chain levels in the blood. So now we are dealing with, so with the hypercalcemia, reduced urine output, volume depleted state, and isolated elevation of free light chains with no albuminuria suggests that it is a light chain cast nephropathy that is occurring. So this patient doesn't have any hematuria. So that rules out any acute tubular necrosis or glomerulonephritis for that matter. So what is happening is a more likelihood of a caste-based nephropathy. So in such scenarios, the priority is to actually very rapidly decrease the light chain fractions in the blood. And what decreases the light chain fraction? We should initiate the appropriate chemotherapy. And literature says that bortezomib is very, very effective in initiating a rapid decline in the light chain fraction, even within 24 to 48 hours. And definitely it has to be accompanied by a high cutoff dialysis, but not without initiating an appropriate chemotherapy. So let's see more about the renal manifestations in multiple myeloma. So the most likely diagnosis in this scenario is multiple myeloma. And what are the various manifestations one can expect is, first is the light chain cast nephropathy, which was a diagnosis in our case. It is the most common presentation of AKI in multiple myeloma, where free light chains are precipitated in the distal tubules and it causes tubular obstruction. That is why this patient did not have any glomerular features like hematuria or albuminuria. All that we could see was the Benz-Jones proteinuria and cast in the urine. Coming to the second manifestation, it is the amyloid nephropathy. Amyloid nephropathy is it involves deposition in the glomerular vessels of all these myeloma-related proteins, and it causes progressive decline in renal function. It is not this acute in presentation. And coming to hypercalcemia mediated AKI, yes, this patient can have hypercalcemia mediated AKI, but a hypercalcemia mediated AKI will not be associated with albuminuria or proteinuria. It will present more with polyuria and dehydration. So the fourth manifestation that is commonly seen is a monoclonal immune complex deposition, which presents more in the lines of a glomerulonephritis with proteinuria, hematuria, and decreased GFR. So the presence of both a tubular issue, which is signaled by the hypercalcemia, as well as a 3+ sort of a proteinuria, narrows our diagnosis to be more likely to be a light chain cast nephropathy. So the other common etiologies of renal dysfunction in multiple myeloma include exposure to contrast agents and exposure to nephrotoxic agents, which are useful in treating the patient, namely the NSAIDs and all the other drugs. Moving on to the next question. So we have a 63-year-old woman with metastatic melanoma on nivolumab, presents with 5 days of fatigue, anorexia, and maculopapular rash, and reduced urine output. She consumed an NSAID for her myalgia. So the ED suspects sepsis, initiate her on a sepsis bundle with IV antibiotics and 1 liter of fluid resuscitation, 1.5 liter of fluid resuscitation. The patient's hemodynamically stable with nil vasopressor requirement and not ventilated. She's admitted in the ICU exclusively because the patient has a severe AKI. The creatinine is around 260. Her baseline creatinine is around 90. Urine analysis shows leukocytes, but the urine cultures remain negative. It is not a significant pyuria. So there is a mild proteinuria, but no hematuria. The urine eosinophils are elevated. So the CRP is also mildly elevated, but thus far the blood cultures and the urine cultures have remained negative. Ultrasound shows bulky kidneys. So we have a lady with fever, fatigue, maculopapular rash, decreased urine output, elevated creatinine, some sterile pyuria, no proteinuria, and no significant hematuria, and some eosinophiliuria. Blood cultures and urine cultures are negative. So the question is, what is the most appropriate next step? So to know what is the most appropriate next step, we should have in mind what is the most likely diagnosis in this condition. Any takers? I think this concept was beautifully explained just now by Dr. Deodita. Sir, anybody, even if they listen to Sir's talk, they will be able to answer this. Anybody?
Swati, you can see the chat box. So there's some replies in the chat box.
Okay.
C, and D. people are saying it is withholding nivolumab, then start corticosteroid.
Right. So whoever said that, they are right. I give it to them. That's the right option. Because nivolumab, as we all know, it's an immune checkpoint inhibitor, and our VNet classically describes the triad that is observed in such patients with acute interstitial nephritis, which is rash, decreased urine output, and eosinophiluria. The symptoms are very, very closely resembling sepsis, but the cultures are negative and the patient doesn't even need vasopressor therapy. So, yes, we got one right answer from the audience. Good going. Let's move on. Question 6. Match the drug with its appropriate mechanism of toxicity. We have some drugs on the left side and we have some mechanisms of toxicity on the right side, but it's all mismatched. One doesn't have to answer all of it. You can even give me one by one. Any takers? Anybody? Am I getting anything in the chat?
Yes, someone has answered gemcitabine TMA.
Yes, that's right. 4 more to go. Anyone? Come on, there are only 4 drugs, and how more can you go wrong? If we finish the common ones like cisplatin, methotrexate, the other options can become easy. Okay, I'm moving on to the answers for want of time. You guys can continue typing in the chat box if you have the right match. So cisplatin, the mechanism is direct tubular injury due to oxidative stress. For ifosfamide, it causes proximal tubular dysfunction. And gemcitabine, like somebody rightly mentioned, TMA. Methotrexate, the classical presentation is a crystal nephropathy. And pembrolizumab, just now we spoke about immune checkpoint inhibitors. It causes immune-mediated interstitial nephritis. So question 5, we have a 63-year-old woman with metastatic ovarian CA, currently receiving a combination therapy with pembrolizumab and bevacizumab. And she also received this recent cisplatin-based chemotherapy. She presents with 2 weeks of nausea, vomiting, poor oral intake, and very diffuse abdominal pain, which has worsened over the last 3 days. She's drowsy, but drowsable, no focal neurological deficits. She denies any alcohol intake, but reports drinking large amounts of water with very minimal food intake. Her initial evaluation reveals severe hyponatremia. She is managed in the ICU with 3% saline promptly at 30 minutes per hour. And she also receives desmopressin, 2 micrograms IV every 8 hours. Despite all these measures, her sodium correction is actually suboptimal. Summarizing, a CA ovary patient who received some immune checkpoint inhibitors previously and cisplatin previously, presents with nausea, vomiting, and severe hyponatremia. So the question is, sorry, we have some more to go. So the serum sodium is around 113. Her chloride is low, 76 millimoles per liter. Potassium is 5.4. Creatinine is 0.6. Glucose is 78. Serum osmolality is 238. Urine osmolality is 542. Uric acid levels are 3.8. So just summarizing whatever is significant, she has a low sodium, a low chloride, a normal to high potassium, a normal creatinine, a glucose which is lowish, serum osmolality which is lowish, urine osmolality as expected, it's a bit on the higher side, but not too high, uric acid which is normal. What is the most likely cause of this patient's hyponatremia? Could it be a cisplatin-induced tubulopathy, or is it SAADH due to the patient's nausea and vomiting and abdominal pain? Is it hyponatremia due to the vomiting per se because of the chemotherapy drugs? Patient had a vomiting due to chemotherapy and which she developed hyponatremia secondary to that, or is it an adrenal insufficiency? Any takers?
3 people have answered as, I think, D.
D or D?
D, adrenal insufficiency, they have answered.
Yeah, I think all our attendees are very smart. The answer is right. Adrenal insufficiency due to immune checkpoint inhibitor therapy. So now why cannot this be a cisplatin-induced tubulopathy? So for this cisplatin-induced tubulopathy to occur, there is one thing which is characteristic. So cisplatin, apart from causing loss of sodium ions, it also correspondingly causes loss of other positively charged ions like potassium. So the likelihood of the patient presenting with a normal or a higher normal potassium is very low if the patient has a cisplatin-induced tubulopathy. Now coming to SADH, we cannot diagnose SADH without a urine sodium. We do not have a urine sodium level here. And another thing to notice is the uric acid of this patient is absolutely normal. So SADH, because of the very nature of dilution, tends to dilute all the electrolytes along with the sodium. And if you read between the lines, the patient's investigation will actually reveal a low normal or a lower potassium, a lower phosphate, a lower uric acid. This is a characteristic picture which we see in SADH. And hyponatremia due to vomiting, so that will again be accompanied by a hypokalemia due to loss of H plus ions from the gastric secretions. So that narrows down the diagnosis to adrenal insufficiency. And why do we get an adrenal insufficiency due to immune checkpoint inhibitors? Anybody? So till now we were talking about acute interstitial nephritis with immune checkpoint inhibitors. But this is another new complication which we are talking about. So what happens is, so these immune checkpoint inhibitors are basically like a toll gate. So their very nature is to inhibit the immune cells from acting against the body's own cells. But this is being therapeutically exploited, wherein these inhibition of the immune cells is removed by these drugs. And now these immune cells are equipped to act against the cancer cells. But now these immune cells cannot only specifically act on the cancer cells, they also act upon various other group of cells in the body, like say the GI tract, the pulmonary tract, the skin, and also the adrenal glands. So they can cause something called as chemical adrenalitis, and that is how the patient presents with adrenal insufficiency. Can we move on to the next one? So question 7, we have a 45-year-old woman with acute leukemia who underwent an allogeneic hematopoietic stem cell transplant 28 days ago. She's on tacrolimus for graft versus host disease prophylaxis. Over the last 5 days, she develops progressive fatigue, confusion, and reduced urine output. Her blood pressure is high, 185 by 100. She's mildly edematous. Hemoglobin is 78. Platelet is 38. LDH is elevated, 5,300, but she doesn't have any overt clinical bleeding. Her creatinine is around 220. It has risen from 90. Her coagulation profile is essentially normal. The direct post test is negative. Is this image clear? So when they did a renal biopsy, it showed something like this. Basically, what it shows is fibrin deposition, and these fibrin depositions are confined to the mesangial cells and some of the endothelial cells as well. What is the most likely diagnosis and the most logical next step? Could it be disseminated intravascular coagulation? Should we treat the AML aggressively because we are dealing with a DIC? Could it be a calcineurin inhibitor toxicity? Should we request tacrolimus trough levels to confirm the diagnosis? Could it be a transplant-associated TMA? Should we request a peripheral smear and LDH? Or can it be an acute antibody-mediated rejection? Should we confirm the diagnosis with a kidney biopsy? Anybody? So we have DIC, tacrolimus toxicity, TMA due to TMA associated with hematopoietic stem cell transplant, and antibody-mediated rejection. So I think D is already ruled out because I have already explained it myself that there is only fibrin deposition. So that's not the characteristic picture in antibody-mediated rejection. So it should be one of the above three options. Anybody?
Two people have answered C in the chat box.
Yep, you're right. So C is the right answer. It could be transplant-associated thrombotic microangiopathy. So why can it not be the other two options? For DIC to occur, the patient cannot have a normal coagulation. If you see in the VNet, that's what it says. It says normal coagulation. And the second option was a tacrolimus toxicity. Again, this can very well fit into a tacrolimus toxicity, but you don't see low platelets and elevated LDH levels in tacrolimus toxicity. Yes, the patient can present with confusion and progress to have a reduced urine output, but somewhere there will be some sort of a neurological manifestation, like either a tremor or a stress kind of a symptom, along with this elevated blood pressure that you see. And also characteristically, patients do develop hyperglycemia in tacrolimus toxicity. So we should specifically look for these things. So the answer is right. Transplant-associated TMA. So question 8. We have a 67-year-old woman with a metastatic breast cancer who presents to ICU with confusion, vomiting, and worsening lethargy over 48 hours. She is on calcium or vitamin D supplements for osteoporosis. On examination, she is extremely dehydrated with a GCs of 11, with no focal neurology and mild peripheral edema. So elderly lady with metastatic breast, with confusion, dehydration, vomiting, and with some calcium supplements in the past. So investigations go like a creatinine of 240 micromoles per liter. The corrected calcium is 3.8 millimoles. The phosphate, okay, I think I missed to write the values. The phosphate is higher side of normal. Parathormone levels haven't arrived yet. Where vitamin D levels are mildly elevated. So the parathormone related peptide levels are also pending. 125 dihydroxybutyrate. Basically, it takes at least a day to arrive. So let's say all these are pending. So echo shows an LVEF for 30%. She's a metastatic breast. She must have received some cardiotoxic chemotherapy before. Correspondingly, her EF is low. Chest X-ray shows condition with increased bronchovascular markings. What is the most appropriate next step in the management? Should we give aggressive IV normal saline and initiate zoledronic acid? Or should we give IV calcitonin and cautiously give low rate fluids and initiate the patient on dialysis? Should we give high dose corticosteroids and stop all other therapy? Should we initiate loop diuretics first to manage the fluid overload, then give bisphosphonates? Or should we wait for the parathormone, the vitamin D levels before any targeted therapy can occur? This is an easy one. Anybody?
That is B, the chat box, no, I didn't B. That
Yep.
calcitonin and fluid and dialysis plan.
Yeah, that's right. So the whole devil lies in the detail in this question also. So any reason why we cannot give bisphosphonate this for this patient, and why we should directly initiate IV calcitonin in this scenario? Any idea? Yeah, let me explain it myself. Like you said, the answer is
Actually,
right.
the creatine is high,
Yeah.
so that's why we should not give and
Exactly. So now we have hypercalcemia, and because of nephrocalcinosis, the patient is already having an elevated creatinine. And for bisphosphonate to actually take off, it is going to take at least a couple of days, even for onset of action. So the priority, although at some point we do have to initiate a bisphosphonate, that cannot precede renal replacement therapy. IV calcitonin, on the other hand, is known to rapidly decrease the calcium levels. So it is better to initiate something which is rapid onset and simultaneously manage the volume overload and the hypercalcemia with a low dialysate calcium, because now you're dealing with a patient who has a heart failure with reduced ejection fraction. And so the fluid margin within which we can play is very, very narrow. So the right option is IV calcitonin with cautious low rate fluids plus early dialysis.
what would be the role of denosumab here?
Sorry?
What is the role of denosumab?
Denosumab.
Yeah. Can
Yes.
you try denosumab here? Yes.
Yes, denosumab
Okay.
can be initiated because that is not renally dependent, and it's definitely a right step to initiate. Yeah. So coming to hypercalcemia of malignancies, we have 4 important mechanisms. First is a humorally mediated hypercalcemia. Then there is our osteolytic hypercalcemia. The third is a vitamin D or a calcitriol mediated hypercalcemia. The fourth would be ectopic parathyroid hormone secretion. Among all these 4, the most common is the tumoral hypercalcemia of malignancy. What do we mean by humoral? It is related to parathormone related peptide. So whichever tumors are capable of releasing a parathormone related peptide, they're capable of causing increased serum calcium levels. The parathormone related peptide, similar to parathormone, it causes renal calcium reabsorption, and it also increases the osteoclast activity, thereby increasing serum calcium. So osteolytic hypercalcemia, we have to look for clues in the VNet or even by the bedside with the patient. We have to look for clues of bone pain, or is there a history of metastasis. That will be more suggestive of osteolytic etiology rather than a humoral etiology. But whichever the case may be, the initial management essentially is the same. So IV hydration or aggressive anti-hypercalcemic measures is the first line management. Vitamin D induced hypercalcemia, the management is slightly different. It is more commonly associated with lymphoma-like conditions, which responds to steroids. So it is essential to do the whole panel, the vitamin D, the parathormone, and the parathormone-related peptide, because more often than not, what we have seen is the same patient can have 2 or 3 etiologies together for a hypercalcemia in malignancy, especially. So last option is the ectopic parathyroid hormone secretion, which is very obvious, similar to what we saw with parathyroid hormone related peptide, similar effects by an ectopic secretion. Let's move on. I think we have come to the fag end of it. Question 9, this is a little bit of a quirky one, which is a real life scenario which we have seen in Tata Memorial Hospital. Let's see. It's a bit of a rare condition. We have a 59-year-old female who underwent hypothermic intraperitoneal chemotherapy, right hemicromectomy, an omentectomy, a diaphragmatic resection with a blood loss of around 1.8 liters. She was shifted to the ward after extubation uneventfully in the ICU. On POD2, she was shifted out of the ICU. She was initiated on TPN in the ward. She was uneventful from 2 to 7 days until the day 7 when she developed confusion and seizures. She was brought back to the ICU. She was put on the ventilator. Her investigations were a hemoglobin of around 10 grams, WBC normal 6,000. Renal function tests were absolutely normal. Her ammonia levels, because she had a seizure, and we were thinking more in terms of any iatrogenic injury to one of the major vessels. So we ended up doing an ammonia vessel, and it was 1,300 micromoles per liter. Her LFTs were normal. CT abdomen was unremarkable. It just showed the postoperative status. So because the patient had seizure, we went on to do an MRI brain. It showed a diffusion restriction in the cortical and subcortical layers, which is suggestive of a cytotoxic edema. So what could have precipitated this seizure and this hyperammonemia in this patient? What is the most appropriate next step? A, stop TPN. B, initiate rifaximin to decrease urease producing organisms in the gut. C, initiate broad spectrum antibiotics and steroids. D, initiate renal replacement therapy. Any takers? Anybody?
The answer is written D here.
Yeah. And can you explain why? And why not the other three? And what could be the possible reason for the situation?
Maybe the urgent reduction of ammonia dialysis is only the most effective treatment.
Agree. But what do you think would have caused the elevated ammonia?
Same.
What do you think would have precipitated the elevation of ammonia?
That may be.
It's a post-operative patient, right? And now we have a lady who is normal LFT is normal renal function test.
Yes.
CT is normal. Where do you think this ammonia is coming from?
Maybe a hypex surgery can also cause some, I think, the role of sometimes the hyperthermia and hypex surgery may cause, and in chemotherapy, they all can cause some elevated ammonia.
Yeah, you're done, right? Just a bit of more refining. So mitomycin C, which is used during the hypec therapy, is very much known to cause an increased metabolic load by rapid destruction of the tumor cells, and the ammonia load in the blood acutely increases. And this becomes especially true with female patients and patients who have a mucinous adenocarcinoma, which is a rapidly proliferating tumor. So this is a very, very niche situation which is observed in a specific subgroup of population. And actually, we could not arrive at a hypothesis that could explain the elevation of ammonia pathophysiologically. Although we did know that it was not cirrhotic in etiology, we know that it is a non-cirrhotic elevation of ammonia, but we still could not explain exactly why ammonia alone should rise and precipitate this. But it can just be kept in mind as one of the rare complications to be looked for in a patient post-hypec presenting with seizures. So that's why I said prior to starting of the session is not only about the most common case scenarios. It also has some bizarre case scenarios. But I'd like all the attendees to keep in mind the basics and the must knows that our senior faculties just spoke about the previous couple of hours. Yeah, I hope that was fun. That's the end of the session.
Yeah. Thank you, Swapna. It's quite informative. And so we're at the end of the session. I thank you all the panelists who joined here, Dr. Ambes, Dr. Rushi, Jigar, Manish, and Dr. Deodit, for your informative discussion and insight and experience. As Nephro, Onco, Nephro critical care continues to evolve, let's take this learning back to the ICUs and improve our patients' outcome together. So stay connected, keep collaborating, and see you at the next session. Good night and take care.